Hello, my name is Victoria and I'm here with my classmates Jacqueline and Paloma, and we are second-year occupational therapy students from the University of Texas at San Antonio Health Science Center, and we are thankful to be able to continue to present our research. Based on previous research, approximately 15% of the world's population has a physical disability, and even with this large demographic of patients, individuals have continued to note significant disparities in healthcare services. After establishing our interest in women's health within the United States, we observed that ADA regulations simply were not enough to establish optimal care for women with physical disabilities. Issues that have been reported were in relation to the accessibility of exam tables, screening tools, and transfer equipment. The purpose of our study was to identify physical barriers that women with physical disabilities face in women's health settings within Barrett County.
We chose a non-experimental survey designed to answer a research question. 277 surveys were sent out through mail and email to physicians across Barrett County. Of the 21 respondents, only 7 of these met our inclusion criteria. We examined what percentage of their patients have physical disabilities, what accommodations they provide, and what they perceive as barriers in their facilities to providing accessibility. It is important to mention that the accommodations that demonstrate higher percentages, as seen in the accommodations provided table, are associated with meeting ADA requirements. Notably, only 14% had sliding boards, transfer protocols, accessible scales, and additional examination time. And none of the respondents had a Hoyer lift. Only one physician recorded having a sliding board, which is essentially the most minimal piece of device for transfers, establishing a theme of lack of equipment and putting patients at risk during unsafe transfers. This is likely because over half of our respondents reported that lack of physical space of their facility is the most notable barrier for providing adaptive equipment for this population.
Also, all but one respondent did not have a transfer protocol in place nor provide employees with training for caring for patients with physical disabilities. This is something interesting to note considering 3 of the respondents worked in hospitals where transfers happen regularly. Additionally, in our literature review, we found that this aligns with women's adverse experiences during transfers, where tragic events such as pregnant women being dropped on their stomachs and other injuries or falls have occurred. One point continuously mentioned in previous research is the importance of wheelchair-accessible scales. Accurate weight measurement is an essential portion of prenatal care, as well as dosage for medicines such as chemotherapy. Astonishingly, only one physician had a wheelchair-accessible scale, whereas others risked not providing women with physical disabilities optimal care without this particular piece of equipment. We identified a possible correlation between the provision of care trainings, transfer protocols, and reported level of physician confidence in transfers. This is seen in Physician E's data, who had a transfer protocol and special care trainings for patients with physical disabilities. Because of this, we can understand why they reported the second highest level of confidence in their personal and their staff's transfer ability. This is a significant finding because this physician also reported having the greatest percentage of patients with disabilities. This remains just a correlation though, as we are unable to decipher if the large percentage of these patients is responsible for the physician's practice having a transfer protocol and specialty care trainings in place, or if the opposite is true, that because this clinic staff is trained to safely transfer and provide special care for this population, that is what's responsible for drawing in the number of patients with physical disabilities. There continues to be a need for research on the benefits of implementation of transfer protocols in facilities and establishing wheelchair-accessible scales as a requirement within healthcare facilities. This is because the barriers discussed in our study likely contribute to a decreased quality of life. A low response rate of 7.58% limits the generalization of our findings, which likely resulted from roadblocks in our survey distribution. To wrap up, our research, through the point of view of physicians, did identify barriers posed within respective facilities for women with physical disabilities. These results illustrate the need for improving the level of care for marginalized groups so that overall quality of life is enhanced. Thank you for listening.